Hello, welcome to the One Health Lens podcast. I'm your host, Dr. Diana Wangari Gitau. We often have conversations around maternal health. And when we have these conversations, we talk about national policies. We talk about global funding. But we don't talk about the real work that's happening on the ground. And on the ground here, I mean county level work. 2 years ago, I was having a conversation with someone working in one of these counties, and we'll get to know which county. And this person said, we have a new innovation. It's called Kausha. And I asked, what do you mean, Kausha? They said, it's a new drug, a new innovation, this person said, that the cleaners are saying once it's used, the floors are clean, no blood in a Kausha, meaning the floors are dry, that when mothers are giving birth, they are no longer bleeding out. This is the conversation. This is the real work happening on the ground. And in studio with me today, we have an organization that helped in this innovation, helped in this county. So I'll let the guest introduce himself and we'll get going. Paul, Karibu.
Thank you very much, Dr. Diana. So my name is Paul Nyachae. I'm the country director for Jhpiego here in Kenya. I'm happy to be here to share what we do and how we partner with governments and the county to, bring innovations to life.
Karibu. And the reason, to be honest, I said I must call you, right, is because if you go to Makueni County now, there's a certain confidence that healthcare providers have. There's a certain pride that you work in facilities, people, not just the healthcare providers, as I said, cleaners, they have. So maybe let's start off with, where does Jhpiego fit in terms of just that maternal health ecosystem? Where do you fit in?
Yeah. So as Jhpiego, we are an affiliate of Johns Hopkins University. And, we've been working across, different parts of the world for the last 50 years. In Kenya, we've done our work for 40 years. And as part of, maybe just to give a history of how we came to be, being a part of the university, it's always about doing research, it's about doing innovation. But I think in those early years, the issue was that if you just innovate, you do your research at the university, but it doesn't impact public health, then you really haven't created the change that you want. That's how we were born, to be able to take innovations that have been tried, researched on, tested, but then bring them to life at the public health space and outside the Americas, just bring them to Africa, Asia, and that's where we currently work. So in Kenya, we worked for 40 years. We actually started as a small organization in the University of Nairobi, worked with a number of OBGYs and professors at that point, and over the years grew in our partnership with the ministry to be able to do a lot more and bring in innovations into the country.
That's good. I like the idea first of translating research and evidence into action, right? We always have this joke around Kenya has the best policies and they always sit on a shelf. Yeah. We are one of the most educated people. I'm glad there's action at the end of all this.
Yeah.
So let's talk about postpartum hemorrhage, right? Hemorrhage, which is essentially when a mother gives birth, they bleed and they continue bleeding after, right? And I'll let you tell us what they were terming as the innovation, right? Yeah. What happened in Makueni County and what is this innovation?
Yeah. So thanks, Diana. So several things, and maybe just to give context again to the innovation. I think some years back, Jhpiego was part of a study to also look at what really does contribute to reduction in deaths of women. As you mentioned, postpartum hemorrhage, bleeding after birth, is one of the leading causes of why women die. So the whole issue around research was, what can we do? What's the innovation? What are the kind of processes we can use to be able to reduce postpartum hemorrhage and the deaths of women? So I think through that trial, it was called the Emotive trial, it was realized that a bundle of interventions done together would easily reduce postpartum hemorrhage by 60%.
60%.
So it was then now at research level that we've seen that evidence. How then do we translate that to practice? So using the emotive part, so the products we have, like For example, tranexamic acid, we have oxytocin, or even part of the what we call uterotonics. So heat stable carbetocin, which is one of the products, is part of that emotive bundle. We also have the uterine drip, which is used to measure blood and just know when you need to act and how quickly you need to act. So this particular drug, heat stable carbetocin, is a uterotonic. It does help contract the uterus so that when a mother immediately after birth does not lose that blood. So we said, okay, how do we work to just make sure that the other parts of the bundle, part of them are there, but then how do we work to make sure this emotive bundle arrives and is actually implemented in a county, and we can actually get to scale with that innovation. So with that, we worked with Makueni. Went into Makueni and started our work in terms of putting together the package of interventions, of which heat stable is part of. So when you hear Kausha and all that, it's this particular drug. And what is innovative about the drug is that you can use other products. For example, oxytocin is an available uterotonic, but then it needs the cold chain. This particular newer drug doesn't require the cold chain. It doesn't require to be put in a fridge. And so you can see the added value for that. If you're in parts of this country where electricity is a problem, cold
Which are
chain.
Many parts of this country.
Yeah, transporting, you have to maintain cold chain. So we actually saw in one of the research that some of the products the oxytocin products are actually ineffective because they didn't follow that cold chain. So the innovation about this particular drug is it's actually heat stable. It does not require that particular cold chain and it works as effective as this. So in communities, in counties where there is heat problems, where there is distance, travel and all that and hardship, then it has that potential to bring impact to reducing postpartum hemorrhage. But then there is work that has to be done to make sure that if you have a new product, you have a new process, how does it actually get into the county system? How is it funded? How does it get actually to be used by clients, eventually translating to the benefits of that innovation?
Absolutely. And so is it correct to say that heat stable carbetocin, right, from a national perspective, it wasn't part of what, let's say simply, was the go-to, right? So we had oxytocin, which, of course, as you've mentioned, needs to be kept in cool conditions, right? Cold storage. So then heat stable carbetocin comes in, right? It's not part of what nationally we say this is the go-to, right? Now, how that process, how do we start by saying you have something new? How do we get to a county like Makueni taking it up? What's the process you went through?
Okay, thanks for that question. So I think for most public health interventions, the evidence has to be there. And I think how it has been is a lot of the public health evidence is generated maybe in multiple countries, sometimes outside, a country like Kenya. So I think the very first step was just trying to say, can we get evidence that these good results we've seen out there can be replicable in settings that are unique to Kenya? So when we came into Makueni County, the first thing was to say, can we identify a set of facilities, work with the county, and be able to introduce these products, work with the county, and see the actual implementation experience and how it happens. And from that, then facilitate scale to additional counties and even additional facilities within Makueni. So in that process, I think there's a number of things. There's leadership, just making sure.
Ask you how does that work?
That the county leadership is aware of the issue. What's the issue and what's the potential benefit. So
they know what's the problem in their county.
Yeah, they need to know. And then they need to know this particular innovation, how is it going to help them? How will they benefit? How will their women, how will their mothers benefit? Cost components, what does this cost? Relative to maybe what is there. All that evidence, we needed to localize it for Makueni to be able to have it taken or scaled up. So there's a leadership component in terms of just making sure both the technical teams, the clinical teams, understand what is this innovation. The political leadership, who allocate resources, understand what is this, what are we losing, what's the financial pain we're enduring that we can resolve with this particular innovation. And then There's also the national teams, because then it's at the health products and technology. You don't want any product from anywhere just coming into the country and getting into, and your clients, your women actually receiving a product without the national team sort of being in the picture. And then of course there's the clients, the health providers,
Yes.
the providers themselves who have been providing care in a certain way. How do you then change the practice so that they're able to adopt this particular new innovation or this particular new product? And then there's work we're also doing that is above board, in the sense that there's work with also the product manufacturers, people who make or develop these innovations are business people. They also are looking at what is the return on investment. But there has to be a balance. If you bring in a product that is very expensive, it's good, but nobody can afford it, you would still not have solved the problem that you had. So also working with the manufacturer and saying, can you reduce the price of these products so that counties can also afford to procure these better or maybe more effective products from you? So there's also the upstream work at that level. And also working with the medical supplies agency. Part of the work was also making sure that how do you make sure that when we are doing this work, after we leave, are the systems in place to ensure that there's continuity for procurement? Is there a way of maybe making the products available at a cheaper price that the country can take on?
Why I like your description of the process is I think many a times when people hear, say, research or something is being tested or something that they're not familiar with has been introduced, there's always that perception that, number one, it's being brought down upon us, that it's being dictated, but also it's not for our benefit, But from what I'm hearing from you, number one, it's an understanding that this is the problem we're trying to solve, so it's needed. It's a problem that's been addressed. This is the solution. But it's not just a solution for the sake of being a solution. It's one that we can adopt and we can sustain, right? But what's interesting in all this is that political leadership piece, because I'm sure it wasn't a factor of that you choose one particular county. I'm sure you maybe considered multiple, right? For it to proceed in one faster than the other, it's always a factor of leadership, right? So goodwill is key, right? Which then begs the question, when you look at maternal health interventions and programs across the country, not just one particular county, what do you think is working, right? And maybe where are the gaps, And I leave that broadly. It doesn't have to be postpartum hemorrhage, but where do you think we are as a country?
So I think as a country on maternal newborn health, I would say we are in a good, or rather we are on the right track. That's how I would frame it, because then when you look at our indicators, they are not really the best. And of course, there's a debate on whether those numbers are accurate, but we always say no mother should die, whether it's one or so, but we have 355 out of 100,000. We're still not where we want to be. But I think the direction we are facing, the path we are walking, is the right path in several ways. So I think one, there's an appreciation of the importance of maternal and newborn health care. Both maternal, there's work that's been going on, but more recently, I think we've been invested also on the newborn components. For your information, we have 6 times more babies dying than mothers. So again, equally, we have to also put a price on our babies equally the way we are doing for our mothers. So that's it. I think the good thing, the direction we are facing that is good, is the fact that there is social health insurance to be able to make sure that a mother does not deliver at home. Because if they're delivering at home because they're not able to access a facility because of cost, then the problems are a lot more. A lot of mothers, a lot of babies die out of just basic infection, and that in a home setting, you cannot guarantee that kind of safety. So the fact that there's a financing mechanism, whether it's working, how best it's working, is debatable. But the fact that it's there, I think, is the right direction that we are headed.
Thank you
I think
for that
Kenya,
statement, actually. At least it's in the right direction.
It is in the
right
direction.
Yes.
Yeah. Of course, there's lots more investments needed, but the direction we're facing is the right direction. I think also as a country, we again, when I gauge with the other 30 countries in which we work in, there's an appetite to always innovate or do things in a better way than previously was happening. So, and I think that spirit of wanting to do things more efficiently, doing better, is a good thing for the country, and that enables these new innovations we are talking about to take hold. I think also when I look, there's a lot of sensitization or community awareness.
Absolutely.
Among our clients. I think, people like you, the nation, media have done a good job in terms of educating women about what to expect when they go to a health facility. So there's a lot of sensitization, and we are seeing sort of the community coming up and asking, why don't we have a health center here? Why are our women dying? And I think if we see that kind of advocacy coming up from our clients, the recipients of this service, it puts on pressure for accountability on our leaders to deliver again furthermore. So we are seeing pockets of that, communities demanding, communities asking for these services, and that's a good sign in terms of where we are headed.
I like that. But a lot has changed in this past 1 year, especially from a funding perspective, right? The landscape has changed. There's less coming in, so to speak, right? Maybe you could tell us, how has that impacted the work you do? What are the changes you're seeing? Do you have a magic ball? You can tell us what you're seeing in the future. How have things changed, really?
Yeah, so I think for the last year or two, there's been sort of a lot of changes in our sector. I mean, as an international NGO, both local NGOs, we've seen a lot of shrinking in terms of donor financing. My own perspective, and I think having worked in the sector for more than 10, 15 years actually, I think there's a good part to it. And the good part, one of it is efficiency. And I think the last, we were having an international conference here in Nairobi, and one of the things the CDC director said that I really liked was, I gave a good example of Congo, and they said, we're losing $700 million, but then we're asking donors to give us $800 million. So why, there's a lot of inefficiency in how things are being done or how things were being done. So I think that focus in terms of saying we have a smaller resource. The good thing it's causing us to do is to really focus on efficiency. How do we make sure that this one shilling, whether it's coming from governments, whether it's coming from donors, how do we stretch it so that it still serves our people? I think the second part is also helping to really define the space of actors like us. Because then I always tell my team, as an international NGO, we are not supposed to be here in perpetuity. Absolutely. There should come a time when we have done our mission, brought countries to where we think, and the countries should be able to run on themselves. So I'm always telling them we need to be able to shrink. If we find we are growing, then that's a problem. It's that the country then, it's at the expense of the country. So we should be, in my perspective, doing very niche things. Like I said, bring innovations that countries can adopt and have them run, implement them for the prosperity of their own people. So I think that, to me, is a realization. And at this moment, I think is helping the community really focus. I think those organizations that had been doing, just receiving money and not doing work, most of them really closed. And because they did not actually have any true value that you can show in your partnerships with government, in your partnerships with county, in your partnerships with the community.
And maybe a little bit on this magic ball. Do you think there'll be more flexibility in terms of funding models to work directly with subnational governments, so the counties? Because I think many people who might be listening in always, and this is a question we even get sometimes here, where people say, oh, but it will go to Ministry of Health, it will go to. So do you think there's going to be more of a shift or positive direction towards working with more subnational governments? Or has that been happening and we just don't know about it?
Yeah, I think for Kenya, it's a unique scenario we are in, because then I think with the devolution came the fact that we have the national government and we also have county governments. And I think what is helping maybe have the shift more to work with the counties is the mandate that counties have, because then mandate have the county to really deliver the service. The national team has the mandate to set in place policies, set in place the structures and systems that enable the counties to do the work. And I think, as you mentioned earlier, for Kenya, we don't have as big a problem on the policy issue. There will come innovations and all this that require a reflection, but I think a lot of the work is really at implementation and supporting counties to make that accelerated move to change. So I think increasingly with much fewer financing, you will see a lot of the focus going into counties and really pushing that envelope. I think there's also a shift to making sure that resources are actually going into the government as a recipient. So again, that's a whole different ballgame, because then when you have government as a recipient, funds can be received at the national level, but then also if they're received at the national level, they have to find their pathway to where the service is actually happening at the county level. So again, there's an accountability mechanism that just makes sure that even if governments are receiving additional resources directly into Treasury, how then do they transition so that the end client at the county level is able to take on and receive services?
I like that. And I wonder why we have never had this conversation before, because there's also this element around evidence, generation of evidence, right? And similarly to the funding question around, we seem to receive a lot of external funding, which apparently is not the case, I discovered. Do we generate enough evidence data, right? And what would it take for that for people to be more aware this is a local data, right? Because you gave us the example, you said, yes, there's evidence generated at an international level, but you had to localize it. What's your experience? Is there enough evidence being generated at county level, and what would it take to make it more visible?
Yeah, thanks. That's a good question, because you see, like I mentioned, we are part of the Johns Hopkins University, and you would find that when you look at universities in general, their mandate is really to generate that evidence. So I think now when we come to Kenya, you'll find that we've tried to work like with local universities to say, your universities in Kenya, what is your mechanism for doing research, for generating evidence that helps our own country? And you'll find in the situation in which we are in currently, the universities which should have been the sole generators of evidence are not in a very good shape to be able even to conduct research, fund research, and do that. So that would have been a very good avenue perhaps to partner with universities at the county level, even at the national level, to generate evidence that's good enough for Kenya. Now, if we come to the counties, we've worked in a number of counties, but you'll find
without naming names.
Yeah. We've worked in a number of counties, but then you would find that the amount of money that is put as a budget to support research, I don't think I've seen counties that have that. So you'll find that you are having to push the envelope in terms of how do you actually generate evidence that shows that maybe interventions are working and all that. So my take on the whole issue is that a lot of work is needed to be able to have counties look at the process of learning as an important part in how they respond and provide services. Because you cannot provide, we got independence in 1963. We cannot just say, once you are employed, you continue providing the same way. What would have informed you to change your practice? And if you're doing it on your own without support of anybody, how would you have informed your own practice? How would you have done reflections and all that? So in our work, for example, we always try to do and push them to do even the lower level, what you call like after action reflections, which will be, we've tried this for 1 month. Has our numbers changed? Yeah. What caused that number to change? Who was responsible in that change? And then, continue that process so that even if you don't have a full sort of research agenda, you're able to use that after action review process to continually or incrementally improve what you're doing at the county level.
And here I was about to say no pressure. You don't have to answer. And I like that, the fact that there's an after action review. Munajita kamkutano, as we say, And I think as we close, it's a question about alignment. How do we align this evidence, this funding? Obviously, there's a problem that we're trying to solve, or there are needs we're trying to meet. Doesn't have to be negative. So evidence generation, there's funding, there's a systems question as well. And in all this, we have to get them to align for the benefit of the people. What alignment and where do we start? I feel it's a very loaded question and very vague and very broad, right? But if you're given this magic wand and you're told, you know what, leave Jhpiego today, yeah? I'm giving you this magic wand, you start somewhere. Or you have two things you do in the next, even let's say 10 years, to bring alignment. Because sometimes even in innovation, you find that it is in silos. Something is happening here, something is happening here. What are 2-3 actions that you think could be a starting point to bring alignment?
Yeah, so I think for me, maybe even to distill it further, my answer is just one. And I think in my reflection, I always look at it as resourcefulness.
Okay.
So resourcefulness, I think for Africa, for Kenya, is the thing that we need, because you will find, again, in the work that we do, you will be in one county that doesn't have resources, you're in another county that doesn't have resources. But one county has figured out how to do the work without as much money. So it's the resourcefulness that people have thought about. For example, just a basic, I don't have money to take people to a seminar. Can I do an online sensitization of my community health workers? It's about resourcefulness. So I feel that if we injected the idea around resourcefulness to all the components of work that we do, whether you are working as a community health worker, you would be able to find resourcefulness in what you do, in how you engage with a mother. If you are a health worker, you'll find resourcefulness when your own county hasn't procured commodities. So for me, resourcefulness can answer a lot. I think the other thing I see lacking and I think would really help is coordination across ministries or across, the different sectors. Right now we are talking about health, but there's a very strong relationship with education. What is the education sector doing to support health? What are we in health doing to support education? There's the environment sector. There's the nutrition components. We cannot have mothers delivering good babies if they're eating poorly. That's an agricultural issue. So I think we still have a lot of work to do to work across sectors and leverage the resourcefulness to make sure that it's for the benefit of our clients.
Thank you. I think when you write this book, call it resourcefulness, And also, as you said, it's also efficiency, isn't it, right?
Yeah.
So I think we'll close the note by asking around maternal health, right? What, if you are speaking today to the people, and what would be, and the people could be leaders, right? It could be community level. Right? What's your call to action so that to improve and have better outcomes in maternal health?
Yeah, that's now the loaded question.
Is it? Not the funding one? Okay.
So I think what we require for, I would say, good health outcomes for our mothers, I think is personal accountability. Personal accountability at all levels. So I am a leader of an NGO. How am I accountable to the resources that I receive to make sure that every woman I am serving is not just surviving, is thriving? I am a health worker who has been left in charge of a busy maternity. How am I taking accountability to make sure that if a woman comes, she's served on time? That does not require funding per se. If I'm in the Ministry of Health, I am taking personal accountability to say, what am I doing to make sure that Kenya has adequate resources, or these products that we have procured have reached the last mile? So I think taking that personal accountability for me would really move the mountains for both our women and children. And personal accountability is also me, the client. What am I doing to make sure I have a good outcome of my pregnancy? For example, am I taking my iron supplements? Am I following instructions to go and visit antenatal care 8 times? So personal accountability at whichever level, I think for me, would give us a long drive in terms of reaching maternal health outcomes.
Fantastic. I like that. Paul, you're a fantastic guest. I appreciate the work that you're doing to support counties. As the cleaner said, Kausha is an impactful story, right? So thank you so much for joining us.
Yeah, thank you. Thank you for the opportunity to also share my thoughts and, to your listeners. Thank you.
Absolutely. Yeah. And thank you so much for joining us on the One Health Lens podcast. Remember, no woman should die when giving life.